All right, so this is Lindsay Luther, and this presentation is going to be a guide to the preoperative assessment of the patient who's having a non-cardiac surgery. This is my sort of the basis of my professional practice, and I can probably talk about this for a really long time. I've recorded this lecture in the past, and it's been really long. So what I'm going to try to do this time is to just break down the key things that I want you to remember, but just know there's a lot more information inside of this presentation if you want to really get into the depths of this, or if this is something you anticipate doing in your own practice. Okay, so basic principles, and I think this is really important to start with. The goal when you're doing a preoperative assessment is not to clear the patient. You're never going to be able to say that the patient has no risk. Instead, what you're doing is you're making an assessment of the risk and you're deciding whether or not the patient is as optimized as possible. So, given everything that we cannot change, is the patient in as good a shape as we can get them in before surgery? So that's going to entail a couple of issues, or a couple of different systems. So there's going to be a cardiac perspective, and there's also going to be an anesthesia risk assessment. You're going to be considering their overall health status and whether or not their chronic conditions are under control. And the other thing to keep in mind about this is that every member of the team has a different priority. So the surgeon is concerned with the area that they're working on. Anesthesia is concerned with basically the ABCs, airway, breathing, circulation. The perioperative staff is concerned about process, timing, making sure that all their ducks are in a row, and they honestly have to be very careful about accreditation and making sure that they're meeting the policies of their organization. Specialists are each going to be interested in their own kind of areas of interest, and so sometimes their recommendations are a little bit, I don't want to say idealistic, but they're a little bit heavily focused in one area. The hospitalist and the primary care provider are really going to be thinking about getting this patient through the continuum of the surgery and the postoperative experience and keeping them healthy. So the role of the pre-admission testing provider is really to balance all of those competing interests and make sure that everybody's priorities are met or met to the highest extent possible. So when we're talking about surgical assessment, timing is really important. We can rate the priority of the surgery based on how significant the impact would be if we delayed the procedure. So if it's an emergent procedure, we get to bypass a lot of our processes like the whole preoperative risk assessment because we know that delaying the procedure to do that would cause a risk of life or limb. Urgent procedures need to be done quickly, but the patient is medically stable to have a little bit of that workup done. And then elective procedures, really we want to make sure that the patient is in the best situation possible. As another principle of perioperative care, anytime we can delay a procedure on purpose, it is better than when we delay it at the last minute. So that means that your job is really to anticipate the problems that could arise, and that will help save money. It'll improve the provider and the patient satisfaction. It'll improve the workflow of the hospital, and it'll also prevent duplication of surgeries. Keep in mind that most planned surgeries happen either in the morning or the early afternoon. Pre-op likes to get all their planned stuff done earlier in the day, and the operating room as well. So you're going to keep that in mind when you're managing some of the patient's issues, especially their medications. So when we talk about doing a risk assessment before surgery, there are really three risks that we're looking at. One is the procedure risk, and that is typically not modifiable. Sometimes we can modify the risk of a procedure by using a different approach, for example, laparoscopic, endoscopic, or a robotic procedure. But for the most part, the surgery they're going to have is the surgery they're going to have. The patient's risk is what they bring to the table. So their control of all their chronic conditions, whether they have any major organ dysfunction like that of the heart, the kidneys, the liver, the endocrine system, if there's a malignancy, and so forth. And then what the patient's functional status is. How well does their heart work on a daily basis, and how conditioned are they to react to situations in which there's stress. Anesthesia risk is the third component of the risk assessment, and sometimes times this is done independently of the preoperative risk, but it's certainly something that you can include and that anesthesia will appreciate if you include. You really are looking for those ABCs, anything that might impair airway, breathing, or circulation during surgery. For example, airway would be impaired by undiagnosed sleep apnea. Circulation would be impaired by if the patient has a propensity towards malignant hyperthermia, and then postoperative nausea and vomiting is going to affect both the quality of the patient's experience and potentially that airway as well. So when we're doing our cardiac risk assessment, the number one guideline that we use is the 2014 ACC/AHA guidelines, and this is for perioperative risk for non-cardiac surgery. Really, the purpose of these guidelines is to decide whether the patient can go to surgery without additional cardiac testing. So you're not deciding just the risk level, but whether or not you have enough information as it stands to qualify the risk. So you're gonna do two different risk assessments. One is the surgical risk, so how invasive is the procedure, low, intermediate, high. Actually, they've been updated since I wrote this initially, and now we just do low and elevated. Same with the patient risk. It's either low or elevated. The old scale used to use low, intermediate, high, and basically you're using their history and their functional status. There are some tools that are available, and one of the tools recommended by the ACC and AHA guidelines is the Revised Cardiac Risk Index. This kind of combines the surgical and risk from the patient into one score, and it assigns the patient to a class and predicts the amount of patients who will have a postoperative cardiac event. So any patient who then falls into one of those high class levels needs to either have some intensive monitoring, or you need to kind of do a stop and think about whether or not the procedure should be done in the first place. So again, there's the 2014 ACC/AHA guidelines. Just a couple things to point out. They have changed, and one of those changes is that they recommend that we use risk prediction models like the RCRI I just mentioned. Another one is the NSQIP, which we don't use in my practice because it's a little bit burdensome. So part of those guidelines is to assess the patient's functional status. There are different ways of doing this. You'll see on the right that this diagram comes straight from that 2014 guidelines, and this diagram helps you to determine what you should do with the patient. So you see that it takes you from, is the procedure an emergency? If the answer is yes, then you just do the best you can, stratify the risk, and then go to surgery. You're not going to delay. If the answer is no, then you first got to find out, does the patient have signs and symptoms of acute coronary syndrome? If the answer is yes, then you're going to go ahead and treat the patient according to the acute coronary syndrome guidelines. If the answer is no, then you're going to estimate the risk of MACE, which is major adverse coronary events. And again, that's going to be based on your clinical and surgical risk. So there is a low risk category and an elevated risk category. If the patient is low risk, we don't do any further testing and they can go to surgery. If the patient falls into one of those elevated risk categories, the next thing we do is look at their functional capacity. So we can use, so there's a scale of functional capacity called the Duke Activity Status Index, which provides us with a measure of the number of metabolic equivalents, or METs, that a patient can reach. So we know that if a patient can get at least 4 METs, then they are a decent surgical candidate. There's no direct contraindication to surgery. So we can ask them questions such as the ones seen here to determine if they're a good surgical risk based on what they can do around the house. For the most part, if the patient can do yard work, if they can walk 2 blocks, climb up a hill, if they can do their own dishes, laundry, housework, that kind of thing, then they're going to be a good enough functional capacity. If the answer to that 4 METs question is no, that is the point when you need to decide whether or not doing more testing is going to change the outcome. If doing more testing is going to help us decide whether or not we're going to do the surgery or which surgical plan is the best plan, then we'll do some more testing with pharmacologic stress testing and then go from there. If the answer is that no, it's really not going to change our plan, or if we know that the patient has a cardiac disease that cannot be intervened in, or if we have recent cardiac testing, then we're going to go ahead and take that patient to surgery and just make sure that we do what we can to to control those risks or make sure that we come up with an alternative to surgery. So I've spoken briefly about the revised cardiac risk index. This slide just goes through what are the components of that, and basically it considers the patient history and major organ system failure, and also the level of risk based on the location of the surgery. So if there's a major heart dysfunction, cerebrovascular disease, metabolic disorder, or kidney disorder, then they'll be at elevated risk, and their risk goes up with each one of those yeses. Okay, so that's our cardiac risk assessment. Let's talk briefly about anesthesia risk assessment. So our anesthesia risk assessment is a kind of multi-component. One thing we look at is the quality of the airway, and that uses the Malampati score, and this is really important before the provider intubates the patient, or if the provider is trying to decide whether or not the patient should be intubated. Sometimes when a patient has a bad airway but they're having a sort of a lower risk surgery that doesn't require a lot of anesthesia, or if the patient's going to be placed on their belly, we'll go ahead and kind of up our anesthesia game plan. So we'll do a more invasive or full intubation and a full general anesthesia, because intervening in the case of a respiratory emergency would be too challenging. So it's always better to do things in a planned fashion than an unplanned fashion. As I said before, we're going to be checking that patient to make sure that no one in their family has a history of a life-threatening anesthesia reaction, the most important being malignant hyperthermia, and also that the patient themselves does not have a history of a life-threatening anesthesia reaction. Patients will tell you all kinds of problems that they've had with anesthesia, and a lot of the time they're either expected complications or they are just normal side effects of the drugs that we use, or their technique issues more so than actual complications. So just know that as a little pearl for your anesthesia risk assessment. We can use some tools to identify patients who may have sleep apnea. The stop bang questionnaire is probably the most clinically useful tool for practice. The thing about the stop bang criteria is that this is not really going to help you a whole lot in terms of changing what you're going to do for the patient. But if you have a patient with kind of a questionable airway and they're not sure whether or not it's better to do like an LMA airway versus a general anesthesia with intubation, it might be better to intubate this patient. Also, sometimes patients with sleep apnea can just be a little bit lazy with their breathing after surgery, and knowing that, we can be a little bit more aggressive. So we can utilize some positive pressure if we need to, or other interventions afterward to take care of these individuals in the PACU. So when you're advising your patients who are about to have surgery, one of the components of that is managing their medications. You need to understand what the goal is in terms of medication for surgery. So 3 principles you want to keep in mind. One is that you want to maintain medical homeostasis. So if the patient is doing well, we want to keep them doing well. We want to keep those chronic conditions exactly in their best place that we can keep them. But we also want to be careful that we keep the stomach as empty of solids as possible, and we want to prevent the adverse effects that can come with anesthesia, such as hypoglycemia. So that said, I'm going to give you a couple things to keep an eye out for. As a rule, you're going to hold anti-diabetic agents, the oral agents, for at least 24 hours before surgery, particularly metformin, sulfonylureas, and any other drugs that cause hypoglycemia. Your insulins, you're going to keep relatively stable if it's a basal insulin. You can reduce the dose to about 1/2 to 2/3 of your usual dose, but this is going to be really dependent on the patient's level of control. If the patient's fasting blood sugar every morning is 200, then I'm not really worried about reducing their basal insulin on the night before surgery, because even if they take the full dose, they're still not going to get hypoglycemic. If you have a patient who's taking prandial insulin or mealtime insulin, you should hold that until their normal diet is resumed. So you're not going to give fast-acting insulin when the patient is not eating. That means that you may want to reduce their insulin a little bit before bed if they take any fast-acting kind of near nighttime or bedtime, and they are not going to take it on the morning of surgery until they start eating again. Medication management, another thing you're going to run into is cardiac drugs. For the most part, we're going to Keep patients on beta blockers, calcium channel blockers, and any long-acting nitroglycerins like isosorbide, mononitrate, or dinitrate, so your IMDRs and things like that. If the patient is on an ACE inhibitor, ARB, a diuretic, or any other blood pressure medication that can cause hypotension with anesthesia, we will have them hold those. Anesthesia drugs are natural hypotensives, and hypotension is usually a bigger issue in surgery than hypertension. So for the most part, we keep the patients on the medications that protect the heart, but we take them off the medications that are designed to work on the systemic vascular resistance. Anticoagulants and antiplatelets are usually held for surgeries, but there's some cases where that's not desirable or even possible, and we're going to get into that in a little bit. But the big things to remember are that you can stop any antiplatelet agent that is used for stroke or that is used for peripheral artery disease. You can stop the ones that are used for atrial fibrillation as long as the patient is not very high risk for DVT or venous thromboembolism. If the patient is on those medications for a DVT or PE more than 3 months ago, or for coronary artery disease with an event more than 12 months ago, you can stop them. There are some situations in which you will not stop the medications, anticoagulants or antiplatelets, without an expert opinion, which is a cardiologist. And those are if the patient has had a PCI with drug-eluting stents placed in the last 12 months, if they've had a bare metal stent placed in the last 30 days, if they've had a blood clot within the past 3 months or a stroke in the past 3 months, or if they have a prosthetic heart valve. So here's what I would say is the approach you're going to take with anticoagulants. You're going to think about the risk of clotting. You're going to think about the risk of bleeding. If you don't know what those are, you need to be asking the specialist. So the specialist for thromboembolism is either going to be the cardiologist or the hematologist, and the bleeding specialist is going to be the surgeon. You should determine what is the appropriate timing of interruption, and you should consider whether or not bridging is appropriate. So I am not going to go into the major things about bridging and what bridging is, but basically the brief idea is that you can take a patient off of a long-acting anticoagulant and put them on a short-acting anticoagulant for a few days before surgery, and that allows you to stop that short-acting agent just for the period of the surgery, and then they can restart the short-acting immediately afterwards, so they're only off anticoagulation for the shortest time possible. The medication that we do that with the most is Lovenox, and if this is something that you do in practice, you can certainly look at this and be aware of this. This is the schedule that I use, and I will actually write this out for my patients and also give them the dosing instructions in each dose, because I think this is really challenging concept for patients. So this is the bridging technique I use for my patients who are high risk in taking warfarin. So a couple more notes about anticoagulants. We usually stop NSAIDs at least 5 days before surgery, and we stop full-strength aspirin 7 days before surgery. We keep a patient on baby aspirin if they have any cardiac history, and you can also continue Celebrex. So Celebrex does not have the same bleeding risk profile as other NSAIDs, and so that's our favorite drug, and we even give it right before surgery for patients who are having some joint procedures. The novel anticoagulants should be held for at least 3 to 5 half-lives. We hold them a little bit longer in the elderly and in people who have poor renal function. So I've listed the drugs that you'll see the most and how long we hold them for. The typical anticoagulants are usually held 5 to 7 days, but before you hold it, you want to check their INR and make sure they're therapeutic. Sometimes the INR will be a little bit high, and if it's high, you're going to need to hold it longer. If the INR is low, you may be able to get away with holding it a little bit shorter. The antiplatelet agents we're going to hold for 3 to 5 half-lives, and most of the time I would say probably 7 days. The half-lives is not quite enough for the antiplatelet agents because a lot of these impair the function of the agents, of the platelets, and so the platelets, although the medication should have worn off all the way, the platelets are not quite right yet in that by that 5th half-life, so 7 days seems to be a pretty good recommendation for most of those medications. Okay, so a couple things that I think are helpful. There is no evidence whatsoever that supports an NPO policy. This was something that made sense to a physician about 40 years ago, and he implemented it into practice, and it kind of caught on like wildfire, and we still do this. There's no evidence that it actually makes a difference. At least just in terms of the policies that we see in our hospitals. So the evidence-based recommendations are shorter. Clear liquids for 2 hours, breast milk 4 hours before surgery, non-human milk, formula, or a light meal, such as toast, would be 6 hours. Fried and fatty foods and meats are about 8 hours. We know that it actually improves patient and nurse satisfaction if we can shorten the fasting period. However, make sure that you're following whatever your institution's policies are, because I have seen anesthesiologists cancel surgery even though there's nothing in the evidence that supports that the patient did something they shouldn't have done. Okay, so some preoperative testing. This goes really well with our 10 pearls of testing, because I'm going to tell you a lot of the same things that I told you in that, which is don't check it unless you know what you're going to do with it. Only check it if it's going to change what you're going to do with the patient, and if it makes sense based on the history, physical, surgical risk, and clinical judgment. And if the surgery is higher risk, you're more likely to offer some labs. So I've included a chart here with some of the labs or testing that we do with patients and why we might do it. And I think that probably is enough to say just know why you're doing it, know what you're going to do with the results, and how it's going to change your management of the patient. And if you're looking at a low-risk surgery, it's probably not necessary. So a couple pearls or tips for documentation. I have pretty much included what I use for my documentation. For my chief complaint, I'll just talk about the reason or the indication for the surgery. I always start my history of present illness with so-and-so is 60-year-old male with a past medical history including whatever, who's presenting to pre-admission testing prior to this surgery by this surgeon on this date, and then I copy and paste that again in my impression at the bottom. When you're working up the surgical concern for your HPI, you want to include prior treatment efforts, you want to include your old cards, and you want to state that the patient's now decided to have surgery or the patient has been referred for urgent or emergent procedure. Your HPI should also include a statement about the patient's functional status and whether or not their chronic medical conditions are controlled. And then I usually also include whether or not the patient has any personal or family history of life-threatening anesthesia complications or difficult intubation. If you can get all of that into your HPI, the team that you work with in your peri-op services will absolutely adore you, because that is everything that every single person on the team needs to know for the most part. The next part of your documentation will be just the basics. So medical history, surgical history, social history, medications, and allergies. You want to look for things like in the medications, especially about undisclosed medical history or any meds that you might need to manage. You want to be making sure that the patient doesn't have allergies to things that you know they're going to be using. One thing that I didn't put on there that we check every patient for is latex. So you need to be thinking about that. For their social history, you really want to be making sure that this patient is going home to an environment where they're going to be able to heal and take care of themselves. If you can anticipate that the patient's going to need some services after the surgery, it is much better to notify the team up front than it is to do it once the patient's already had their surgery and they're sedated and now you're trying to work out some logistical issues while the patient can barely participate in the conversation. Documentation of your review of systems. Basically, you're going to go through each system and you're looking for any problem that might interfere with the safety of surgery or anesthesia. So active neurologic conditions or infectious conditions, any issues that like dyspnea or orthopnea or edema that might indicate pulmonary or cardiac issues, if the patient's actively bleeding from the GI tract or the genitourinary tract, or if the patient has any rashes or lesions that are going to be in the way of the surgical site. If the patient has any indications of bleeding or clotting disorders that might need to be worked up. And then finally, and I think this one gets missed a lot, is looking for anxiety, depression, and panic attacks and post-traumatic stress disorder. A lot of patients have had stressful medical situations, and those patients can be very challenging in the PACU because they wake up disoriented and scared, and sometimes that will kick their PTSD in. So again, just helpful to know these things before the patient goes in. When you document your physical exam, you want to just do the whole shebang. You want to pay special attention to the heart, the lungs, and the surgical site. And then your impression is going to repeat that same sentence from your HPI, which gives a summary of why the patient was here and what they're going to have done. The diagnosis is going to include the surgical concern as number 1, and then you're going to rank all of the comorbid conditions in the order of importance. So your plan is why you were doing this. So that should include your cardiac risk assessment. And I include the guidelines that I used to do that risk assessment. So I mentioned my 2014 ACC AHA guidelines, and I mentioned my RCRI score. I will do a sleep apnea assessment based on my stop bang criteria. I will talk about how the patient should change their medications, and I'll document that the patient has been given verbal and written instructions and also what those instructions were and that they understood them. I will make some recommendations for post-operative monitoring, and then if there are any concerns about discharge planning, I will note them in my plan there as well. So a couple tips and tricks for documentation that will make you a better member of the team. Always document the BMI. The BMI is really important to billing, especially the difficulty of the case for the surgeon, so you can help your surgeon to adequately reflect the difficulty of their case by including that BMI. It's really helpful to note whether the patient needs assistive devices, because these will be really important both in PACU and when the patient gets up to the floor or when you're doing discharge planning. It's really helpful if you can document some of the psychosocial needs you might anticipate. For example, if the patient is a primary caregiver for another person, or if the patient has a history of PTSD and may have some trouble with emergence from anesthesia, things like that. And then finally, and this is my number 1 tip for your physical exam, always use a stethoscope and always document that you used a stethoscope. You need to be checking for the patient's heart sounds and lung sounds. I see all the time, especially in the emergency room, regular rate and rhythm, normal lung expansion, no stridor. That is not a sufficient cardiopulmonary exam for a patient going to surgery. And so I expect you to use your stethoscope. So finally, in the presentation, I've included some special populations considerations, and I'm just going to scroll through them really quickly because I want you to know they're here. So a couple surgery populations we run into that have some specifics include your bariatric surgery population. These will have different testing that is required depending on their insurance coverage in order to qualify for the procedure. And they may need some consultations from different professionals or some classes. And so with these patients, you're going to make sure that you document whether or not those patients have gone through those procedures appropriately. You always want to make sure that you document the BMI and comorbids in order to make sure that they get that coverage. Total joint replacement is the pre-admission testing process is a standard part of the enhanced recovery pathway, which is an evidence-based modality for improving outcomes in total joint replacement. Usually they have to have some sort of perioperative education, and when you're doing your documentation, and you may want to consider talking about discharge. So are they going to go to an extended care facility? Are they planning to go home? And there's some other testing that will be done depending on what the procedure is and the surgeon's preferences. So things like nasal culture for MRSA and urine culture. Elderly patients, I just want you to be aware that the age does not independently predict the risk of surgery. So just because a patient is older does not mean they are higher risk, but they are more likely to have concurrent comorbid conditions, and your threshold for testing things may be a little bit lower. And then furthermore, the benefits of surgery may decrease with age. So when you're doing that risk-benefit calculation, you're going to want to take into consideration longevity and the difficulty of the procedure and whether or not the benefit is still going to outweigh the risk. There is some question in the evidence about doing frailty assessments for elderly patients. This is not currently part of our practice, but is something that we're kind of looking at. So some places are doing this and some places are not. A couple other things that you may run into. It is not uncommon to do anesthesia for non-surgical procedures. This will still require a history and physical assessment. This is really common in children, but you're not going to have to document a surgical risk, and so you're going to be kind of just be doing that anesthesia risk assessment. There are also some non-surgical procedures without anesthesia that will require a history and physical, and you can typically skip the cardiopulmonary risk assessment, but you do need to be looking for things like bleeding and positioning and making sure that the overall stress on the patient is not excessive. So to sum this up, I think there are a couple good questions to ask yourself when you're thinking about sending a patient to surgery. First thing is there an absolute contraindication? So if there's a really good reason why they shouldn't go, then that should be a hard stop, or at least a conversation that you need to move forward with. The next question is, does the benefit of surgery significantly outweigh the risk? And again, this conversation is going to have to involve a lot of different people. So it's the anesthesia team, the surgeon, the patient, and maybe others depending on what's going on. If you're not sure, then that's when you should think about whether or not more testing will help you to estimate that. And then the last question that you should be thinking about is whether or not there's anything you can do to make the surgery safer for the patient. And that might mean anything that you can educate the perioperative team about or notify them about, if there's anything that the patient should change or any way you can optimize the patient, if the patient needs any education, and if there's a post-operative plan that you can get into place to make sure the patient is safe. So I'm pretty excited that I managed to get all this done in only 32 minutes. As I said, I could talk about this stuff for hours. If you have any questions, I am more than happy to answer them. And if this is something that you have a strong interest in learning more about, let me know, and maybe we can just arrange for a day that you could spend in our pre-admission testing clinic over at Grove City. And again, please let me know if there's anything I can do for you. Thank you.